as well as private care delivery system. Now, most people actually prefer to die at home as opposed to being hooked up to tubes in the ICU. And over the years, more people have been able to die at home. In fact, in 2017, it surpassed even deaths in the hospital. Still, a large number of people are also dying in the hospital, in nursing facilities, and a growing number of people are dying in hospice facilities as well. I'd like to start with a case. This is a lady in the emergency department who's been getting weaker, developing shortness of breath, nausea, anxiety, decreased appetite, fatigue. She developed some palpitations and chest discomfort and has underlying AFib and severe AS and a pacemaker. And she was found to be hypotensive and hypoxic on evaluation, and eventually she became obtunded, unable to swallow, was having oropharyngeal secretions, has jugular venous distension, heart murmur, crackles, edema, peripheral cyanosis, mottling, and a capillary refill that is prolonged. EKG is consistent with aneuroseptal MI, probably sometime within the last week. She has cardiomegaly and congestive changes and elevated troponin and low sodium. And she was placed on non-rebreather, and eventually she fought that off and didn't tolerate BiPAP. That is before she became obtunded. IV fluids were given because of hypotension, but again, the impression was cardiogenic shock. So it was really difficult to know if they should even give fluids to support blood pressure. And the medical treatments were rapidly failing. So the emergency department called me to see her in the ED to address goals of care and provide symptom relief. And so some of the key questions to ask when you're faced with not just patients who are obviously actively dying, but ones that may be getting closer to end of life, like within the next few weeks. So how can you recognize when death could be around the corner? And how can you notify patients and families so they can plan appropriately? What are the person-centered goals of care? What's most important to them? Is it curative treatment, including ICU care? Is it comfort care, or is it something in between? And another question to ask would be, if death is imminent, where does that patient want to be? Do they want to stay in the hospital? Do they want to try to get home with hospice or to a hospice facility? What needs to get done? And what are the family concerns at end of life? Oftentimes they have some very specific questions, and we'll go over some of those. And then what's involved in comfort care? Family says, well, we just want comfort care. What does that mean? And how do we get the symptoms controlled rapidly? And as a physician, there are certain tasks that you do have, and that one of those is prognostication, and also communicating honestly and providing anticipatory guidance, discussing realistic treatment options, weighing the risks, benefits, and alternatives, helping them cope by providing information and support, anticipate and treat distressing symptoms, and of course, pronounce death and sign the death certificate. So what do people really want at end of life? Actually, good communication and compassionate honesty is very important. It's even more important. Actually, control and dignity is more important even than the physical comfort. But most people will say, well, I don't want to suffer. Their family members will say, I just don't want him to suffer. Most people also don't want a prolonged dying process or be a burden on the family. And they want to be able to enjoy some meaningful activities at end of life, come to closure. So specifically, you can break down the support needs into 4 basic categories: physical, such as symptom management; psychosocial; spiritual, especially with fears of dying, feelings of being at peace or closure, and then bereavement needs; and hospice, the location of services, where would that occur, at home or in a facility? How available is family to provide 24-hour care? What agencies are geographically in their region? And is the patient even stable for transport? So how much time is left? This is the million-dollar question. Everyone wants to know this. And of course, we don't have a crystal ball. We don't know precisely how much time, but we do have some clues that we can look at to make an educated guess. And one of those is considering the pattern and rate of decline. And then there are some prognostic tools that we can use and physiologic signs. So in general, when someone has severe acute illness, obviously they have a potential for a much worse prognosis, or if they have underlying advanced or end stage disease. if they have rapid decline in function, nutrition, or cognition. In fact, sudden functional decline is a harbinger of death many times. Debility, frailty, advanced age, and poor reserve, and a history or high risk of sudden decline, such as with vascular events, bleeding, infection, obstruction, or aspiration. We have a separate lecture this year on prognostication. I'm just going to introduce the topic. Basically, there's lots of disease trajectories. You can have sudden catastrophic decline from acute illness. You can have a period of relative stability and then rapid decline, such as cancer. A fluctuating downhill course, such as organ failures like COPD or congestive heart failure, any one of which could end up with them dying, or they could recover, but in general, the trend is downward. And then finally, the slow gradual decline, such as seen in frailty and dementia. These two tools are very helpful near end of life, and they often will help clue you in that, hey, somebody might die within the next month, and so we better have some conversations about what's important and what kind of care they would or would not want. A palliative performance scale, I'm going to focus on the 10 to 50% range instead of the upper one, but basically it looks at, how well can they walk? Can they do any activities or work, self-care, oral intake, and then level of consciousness. And so 50% this is somebody who's mainly sitting in a chair or lying in bed and can't really do any work and needs some assistance. 30% is someone who's totally bedbound, and then 20% is where you're down to just SIPs and require total care, and then 10% would be somebody who's obtunded. And giving estimates in terms of ranges, days to weeks, weeks to months, or perhaps even hours to days if someone is actively dying. What's interesting is that 90% of patients with a palliative performance score less than or equal to 50% are dead within 6 months. And why is 6 months important? Because that's the period of hospice eligibility. If your estimate is that they will pass away within the next 6 months, more often than not, if the disease runs its usual course, then this tool may help get them in the door for hospice eligibility or appropriateness. Whether or not they want hospice is a different issue. 3 factors predict survival less than 4 weeks. So if they're losing a significant amount of weight, if they're experiencing cognitive failure, and if they have dysphagia to solids or liquids. Now, the Palliative Prognostic Index uses the Palliative Performance Scale as part of one of the 5 factors that it looks at. Another one is oral intake, edema, dyspnea, rest, and delirium. It's scored 0 to 15. And a score greater than 6 predicts survival less than 3 weeks with at least 80% sensitivity and specificity. So this is something it kind of clues you in that, hey, somebody might not be around much longer. Let's have some conversations. It's not a perfect tool, but it also can be followed over time. And if somebody's score improves, then their prognosis is likely to be longer. Or if it's rapidly getting shorter. Yet the rate at which someone is declining is predictive of the future rate of decline. So let's talk now about some of the signs, the physical signs of dying. Within days to weeks, people start having more fatigue, getting weaker, losing appetite, maybe becoming more sleepy and lethargic. Eventually, they may sleep most of the time. Once they start getting to the point where they have vital sign instability, that's when you're looking at hours to days. So tachycardia, bradycardia, or variation, back and forth, low blood pressure, fever, becoming more difficult to awake and or becoming comatose, diminished peripheral blood perfusion as manifested by mottling or cyanosis of the skin. Also, irregular respiratory pattern, the fast then slow pattern. They may start to develop rhonchi and pooled secretions. They may lose their gag reflex and ability to swallow. They may become oliguric or anuric and lose sphincter control. Here's a graphic, extreme examples of modeling of the secretion issues and the Shane-Stokes irregular respirations. So families become very concerned. when faced with the potential death of a loved one. Universally, they say, I don't want my loved one to suffer. So we're going to look at some of the different areas more specifically that they might consider. So this question comes up not infrequently, because someone's health is getting worse. They're starting to get to the point where they don't even want to eat. And families concerned about her starving to death. I don't want her to starve to death. And so, part of the love language that families use is feeding. And if somebody's not eating, then they feel like they're rejected. And it can make, and people also project their own feelings. They think, well, if I'm not eating, then I would be suffering because I'm not eating. But the reality is that the patient is not technically starving to death, because in the last few weeks of life, the body switches to a catabolic state. Even if they're on TPN or tube feeds, what we find is that the albumin and prealbumin levels start dropping despite artificial nutrition. And the loss of appetite is actually normal for this stage of life. Food is not appealing, and if someone does eat, it might be just a bite or two, and that anything more might make them feel too full or nauseated. And that the artificial nutrition is actually not incorporated into the body and does not prolong survival when someone's in the dying process, and it can increase symptoms. People can live comfortably on just sips or bites for up to 30 days for food, and up to 14 days if they're not drinking anything. Artificial nutrition may actually worsen their symptoms of secretions, nausea, dyspnea, or bloating, and so families should be encouraged to find alternative ways to nurture the patient. Now, what does it look like to focus on comfort, or to do comfort care? So that involves nursing care issues like limiting vital signs, maybe to once a shift, with the exception of the respiratory rate. And generally, I recommend doing that every 4 hours, because that's a non-invasive way to assess if they're short of breath, if they're in pain, anxious, because if they are, then their respiratory rate is going to be high. On the other hand, if the respiratory rate is really low, that could mean that they're about to pass away, or perhaps the dose of the opioid that they're getting is becoming too much. Mouth care should be given, including lip balm, eye drops, eye care, or ointments like Lacrolube. Skin care, turning every 2 to 4 hours is tolerated because they're now too weak to turn themselves. And even using an air overlay mattress to prevent pressure sores in the last few days of life. Foley catheter is usually helpful because otherwise they might be incontinent. Discontinue non-comfort measures such as medications that are not really helping with their comfort, or if they're unable to swallow pills anymore. Testing like labs or x-rays, cardiac monitoring, and then consideration of withdrawal of artificial life supports or ICD activation. I've got a slide on that toward the end. And then adding medications to prevent or treat symptoms. So probably the most common symptoms that you'll come across would be pain, shortness of breath, anxiety, restlessness, and agitation, then secretions. Patients may develop fever. Universally, they are not hungry. They may have some nausea, itching, and fatigue, and lethargy. And we'll touch on most of these. So dyspnea and advanced heart and lung disease. Healthcare professionals are ethically obligated to treat dyspnea, and patients should be asked to rate the intensity of their breathlessness as part of a comprehensive care plan. Opioids should be dosed and titrated for relief of dyspnea in the individual patient. Both the patient and clinician should reassess whether relief of dyspnea in specific treatments are serving the goal of palliating dyspnea without causing adverse effects. And it is important for clinicians to communicate about palliative and end-of-life care with their patients. And this is from the ACCP consensus statement on management of dyspnea in patients with advanced heart or lung disease. So opioids are first line for moderate to severe pain or for dyspnea. Preferred routes are IV, oral, sublingual, subcutaneous. In a pain crisis, or if they're having extreme shortness of breath, you can bolus dose IV every 15 to 30 minutes and escalate until they become comfortable, and then use maintenance dosing after that. Some examples: morphine 1 to 2 milligrams, fentanyl 25 to 50, hydromorphone 0.25 to 0.5. Those are all equivalent dose ranges. If someone's opioid tolerant, you can increase their baseline dose or use a different opioid. If their symptoms are not controlled, you can continue to escalate the dosing until they develop respiratory depression. And the risk of overdose is increased if they're on more than 90 morphine milligram equivalents per day. If one opioid doesn't seem to be working, you can change it. You can increase the dose. You can change the route. You can consider adding NMDA blockers such as methadone, ketamine, or dextromethorphan. Use a continuous IV infusion or PCA pump. We touched on this last week, so quickly review IV opioid infusions, and this is for ongoing severe pain or shortness of breath despite frequent IV boluses. And it evens out the medication, so there's less sedation or hypotension risk. And remember, IV boluses are what you give if you want someone to get comfortable. Whereas once they're comfortable, and if it looks like they're going to live long enough, then you can add a drip to maintain pain control if you expect it will be ongoing. Morphine is most commonly used, followed by fentanyl and then hydromorphone. Consider the individual patient factors. And again, these are equivalent ranges between the morphine, fentanyl, and hydromorphone. Now, toward end of life, you do need to adjust opioids. So as they lose weight, they lose sub-Q adipose. So fentanyl patches aren't going to be as effective. So using oral or sublingual routes or IV. Fever is often present at end of life, and that makes the fentanyl patch more readily absorbed. And so someone could potentially become more somnolent or even run the risk of respiratory depression. If they have dysphagia, use mainly IV, sub-Q, sublingual, transdermal, or rectal routes. Dehydration, renal, or hepatic failure. So again, you're going to want to use lower doses because the dose will be more potent and around longer. And use mainly PRN doses, so avoiding the long-acting or scheduled dosing if they're going into organ failures like that. And specifically with renal failure, you want to avoid codeine and tramadol, and also the extended release forms of morphine or oxycodone. Preferred medicine is actually fentanyl, but also methadone, buprenorphine, hydrocodone, or hydromorphone are acceptable alternatives. And with most of these, you would probably need to reduce the dose or spread out the frequency. We touched on this last week. I'll mention it again for those who were not on the call last week, but this question always shows up on the boards. This principle of double effect. You give a medicine and someone dies afterwards or develops severe respiratory depression. Did you kill the patient? No. The medications themselves, when dosed in proportion to the symptoms, don't kill patients. Most of the time, they do the opposite. People actually live longer. But the purpose is to relieve suffering, not to kill the patient. And death after administration of opioids is due to the underlying disease and not due to the medication. And we have an ethical duty to provide relief of symptoms, comfort care, especially at end of life. And this is supported by ethical statements from the AMA, from the Catholic ethical and religious directives, all very specifically address the issue of pain management at end of life and the ethical obligation to treat pain and to prevent suffering. Now, anxiety is another big symptom, and there's a vicious cycle between shortness of breath and anxiety. The more short of breath someone feels, the more anxious they feel. The more anxious they feel, the more short of breath they feel. And so there are management strategies such as identifying what is causing the anxiety and then using medications appropriately or psychosocial interventions, relaxation techniques, addressing psychosocial and spiritual concerns involving chaplain services, social workers, providing companionship. Having a fan at the bedside helps not only with anxiety, but also with shortness of breath. And anxiolytics may be useful if opioids are insufficient. That is, if shortness of breath is the cause of the anxiety. So short-acting agents such as lorazepam or even midazolam if they're in ICU type of setting. If someone has a longer prognosis, then you could consider clonazepam, especially as an outpatient. Terminal restlessness. This is another phenomenon that may occur toward end of life. People call out for dead family members or friends. They talk about taking a trip. They may be, I had one lady, I walked in the room and she was talking to someone who wasn't there, obviously. And I said, who are you talking to? And she said, oh, my husband. And I said, oh, is he still alive? And she said, no, he died a few years ago. But she looked totally comfortable, was calm. So people start having either dreams or even what seem like hallucinations of seeing or talking to deceased relatives. And it really freaks the family out, but it's actually a normal part of the dying process. And it can occur even days before death. Considering the differential diagnosis of somebody who seems really restless at the end of life, is it because they're having untreated pain? Or are there drugs such as benzo or opioid or SSRI withdrawal? Kidney or liver failure or electrolyte imbalances can make people delirious. Fecal impaction, urinary retention, or Foley occlusion. And then, of course, psychosocial and spiritual factors, especially fears of being alone. And delirium with agitation is actually one of the most challenging symptoms to treat. And we've got a lecture on delirium later in the year. But in general, treat the underlying cause if possible and if appropriate. If you need to use medications to get somebody calm enough to be safe for themselves or others, then you can use IV or sublingual or even sub-Q haloperidol. You can use olanzapine, quetiapine, chlorpromazine, which is very sedating, and that's often used more in the outpatient setting. Trazodone may be used. Quetiapine tends to have the least extrapyramidal side effects, so that would be preferred if they have a tendency toward Parkinsonism. There is an FDA black box warning for increased mortality in the elderly and the risk of QT prolongation. So usually at end of life, the symptom benefits outweigh the risks, and families just want to get the patient comfortable. And sometimes the only way to do that is to get them to sleep. And so the antipsychotics can certainly sedate people. Oropharyngeal secretions, colloquially, people call it the death rattle. I don't care to use that term with families because it sounds kind of harsh, but just be aware of that. That secretions toward end of life are not uncommon. Repositioning and postural drainage may help. Suctioning most of the time just causes more trauma and doesn't necessarily help, because this is more secretions in the upper airways as opposed, from decreased ability to clear secretions. And then anticholinergics may be useful for severe symptoms or if there's family distress despite education or reassurance. Now, recently, there's been reference in the medical literature to abandoning anticholinergics altogether, really because the patient themselves is not aware of this. It's more what the family perceives. And so technically, from an evidence-based medicine standpoint, most of the time, the medicines don't help the patient feel better. But I can tell you from personal experience that it sure helps the family be more at peace, because there's nothing more haunting than in their memory, hearing that gurgling sound at end of life and perceiving that their loved one is drowning or suffering. And so sometimes we use these medicines just to make it more peaceful for the family. So glycopyrrolate can be given orally if they have a G-tube, or IV, and it does not cross the blood-brain barrier, so it shouldn't be sedating. Scopolamine patch may also be used. Typically, it's placed behind the ear because the skin is very thin there and it gets absorbed quickly. But it takes a few hours to begin to kick in, but it lasts longer. Hyoscyamu is another option. So oftentimes crushing a tablet and putting it under the tongue, or atropine drops, atropine eye drops, given sublingually, do act pretty quickly, but they can cause CNS or cardiac excitatory side effects like tachycardia. So just be aware that these are some of the options available. And sometimes if the secretions are really bad, we end up using 2 different things instead of just one. Fever. is often due to atelectasis or could be due to infections. And obviously using cool, damp cloths, cold packs, fans, and then medications like acetaminophen, NSAIDs, or even dexamethasone can be useful. Nausea or vomiting. And then again, there's a separate lecture on this during the year, so I'll just touch on this very briefly. So this could be caused by medications, uremia, bowel obstruction, ascites, gastroparesis, gastritis, dehydration, or increased intracranial pressure. Obviously, reducing any medications that aren't helpful or might be causing symptoms, and then focusing on the oral preferences of the patient, like whatever they do feel like eating or drinking, if anything, and using antiemetics, either IV or oral dissolving tablets like ondansetron. Rectal prochlorperazine may be used, oral or IV metoclopramide if they don't have prolonged QT. And then second line meds like dexamethasone or haloperidol, olanzapine, for example, especially with chemo-related nausea and vomiting. And then if they have malignant bowel obstruction, then consider the combination of decadron and octreotide, which reduces bowel wall edema and intraluminal secretions. It also helps if they have IV fluids and NG drainage in that situation. Pruritus or itching, often seen in renal failure and exacerbated by morphine. It's not an allergic reaction with morphine, it's because of direct mast cell release rather than an IgE-mediated reaction. And usually cool washcloths on the skin can help, skin moisturizers, antihistamines can help, and also gabapentin. Now, no talk about care of the dying patient would be complete without mentioning the option of what to do with people who are on life supports. And so it's important to know that ethically, legally, and morally, refusal or withdrawal of artificial life support is permissible. There have been many landmark cases over the past few decades that have addressed this issue. Just because you can start something doesn't mean you can't stop it also. In other words, they're equivalent. You can give a treatment or you can remove a treatment, and it's based on the benefits versus the burdens, and also on the patient autonomy or surrogate decision maker acting on behalf of the patient. What would the patient want? And if the patient or family sees more burden than benefit, then the treatments can be withdrawn. And this allows natural death from the underlying diseases rather than prolonging life artificially by machines. And that's a good way to phrase it when you're talking to patients or families, especially families, because they feel like they're killing grandma by taking her off the ventilator. The reality is that she would have died, and now this is just prolonging the dying process by a machine rather than saving her life or helping her get better. So many examples, of course, mechanical ventilation, BiPAP. And most patients, they have a limited tolerance for BiPAP. You know, after a couple hours or even a day or two, they're done. They don't want it anymore. It's uncomfortable, it's tight, their nose bridge skin starts to break down. Especially during COVID, we saw a number of people stuck on high flow, and eventually some of them got to the point where their bodies started to shut down despite the high flow. Or perhaps they got to the point where they realized that that was the only thing keeping them alive. And after several weeks on it, they realized that's not how they want to live in the hospital. Other examples are vasopressors, dialysis, which is a less dramatic form of life support, and cardiac devices, particularly balloon pumps. However, pacemakers or LVADs are not typically withdrawn because they're implanted devices. Prognosis after artificial life support removal is variable, and it depends how critical the patient's condition is and what life supports need to be withdrawn. So for things that are more dramatic, like ventilators, vasopressors, and balloon pumps, most die within a few hours. It may be as short as minutes or maybe as long as days. Every once in a while, somebody survives and they end up living far longer than expected. Dialysis, average survival is 7 to 10 days once it is stopped. Range is 1 to 14 days, but longer. If they're able to urinate some, there have been people that have lived even months. Lethargy and coma usually occur within days before death. So it's not a distressing or a painful death. It's just they become encephalopathic, and then just kind of gradually the body just shuts down. Eventually, they have usually an arrhythmia because of hyperkalemia. Now, when you are withdrawing the ventilator, another phrase is compassionate extubation or ventilator liberation. It's important to document your discussion of comfort goals of care with the family. And once the decision is made, then the staff will notify gift of life. It's important to know that gift of life and the medical team are supposed to operate in two completely separate spheres to avoid any potential perception of a conflict of interest. So in other words, we're not, in there trying to promote it, or, we just, once the decision is made, then the staff can notify gift of life. Gift of life can talk to the family, and they can decide if they want to donate or not. And also providing anticipatory guidance and spiritual support for the family is important, seeing if they need a chaplain or if their pastor wants to come, and helping them know that pre-medications will be given to prevent symptoms, but also medications will be readily available once the tube is withdrawn to make sure that their shortness of breath or air hunger is controlled, anxiety or restlessness or secretions. So this will help the family know that, yes, we're not just abandoning the patient, pulling out the tube and walking away. No, people are there, they're assessing them, they're giving medications, they're escalating doses if needed. So there will be active comfort care. Then once the pre-medications are given, usually it takes at least 15 minutes, then the ET tube the cuff is deflated, the tube is removed, as well as the OG tube, and suctioning is done. The patient is cleaned up from any secretions that may have gotten on their face or on themselves. And then usually the family has stepped out for this because the suctioning is kind of distressing to hear. And then the family comes back in and spends time at the bedside for however long it is. And then using bolus doses, titration of opioids, drip, if they're going to live hours to days. Because by the time you hang the drip and it actually reaches pharmacologic steady state, you're talking hours later. So it's not really for somebody who you think might die within the next hour or two, really for somebody who might live 4 hours or more. And if you expect their symptoms are going to be ongoing and moderate to severe. Generally, we target the respiratory rate less than 20 to 24 per minute, and also looking at body language. Do they look relaxed? Are they grimacing or appear agitated or restless, or do they appear calm? And I also want to touch on grief and dying, and the stages of grieving, and talk about normal versus abnormal grieving and depression, and distinguishing grief from major depressive disorder, because you'll see this on the boards, and also because it's important to anticipate and be able to treat this effectively with patients and families. So you've probably all heard of Elizabeth Kubler-Ross, who in 1969 wrote a book called On Death and Dying, which really opened people's eyes to what it's like and the experience and what to expect, what's considered the normal reaction. And often the first reaction is denial. And I'm sure, seen this many times, especially in the ICU. Families, they just can't believe how sick someone is. They were fine last week or yesterday, and now they're on death's door. That can't be. Or, oh no, it can't be cancer. That pain that they've had. No, that's just musculoskeletal. So there's a lot of denial that goes on. And oftentimes when people are in denial, not denial and anger, so that you get the emotional reactions first. And so you have to be able to respond to those emotions and just don't take it personally if they take it out on the messenger, if they are mad at you because of what you represent, which is, disrupting and threatening everything that was comfortable to them before that point. This news of the fact that someone might die is totally unwelcome. It's never the right time in someone's life. This is always an inconvenience, and it throws everybody's plans off, family members, the patient. And so there's going to be a lot of reaction. And so being able to respond with empathetic statements, recognizing the denial and the anger, recognizing how hard this must be, how we wish things were different, how we're sorry to have to give them this news, but we wanted to be honest with them and make sure that they understood that this is serious and that death is a very real possibility. And then families go through a stage of bargaining, or even patients go through this stage too. And then maybe some depression, and then eventually acceptance. Now, people don't always go through all 5 stages. Sometimes they skip from one to the next. But generally, when they get to the acceptance stage, then they're going to say, instead of saying things like, well, how can you be sure, which is representing denial, the acceptance stage says, so where do we go from here? So what's next? So I just want to be comfortable, or I just want him or her to be comfortable. Then you've been given the green light to go ahead and talk about, what does comfort care look like, and how can we match the level of medical care with the desires of the patient and the family. And that helps bridge the enormous gulf between you and the patient and family. Grief and bereavement is an important topic. And National Grief Awareness Day, August 30th. I'm not sure how you would actually celebrate that. I don't think it's not the kind of thing you want to celebrate, but it's more like bringing it to people's awareness. And there's lots of resources. I mean, you can Google it, but there's different publishing companies that have pamphlets or booklets that are for patients or families on a whole host of topics related to grief, depression, bereavement, etc. And of course, hospice services offers bereavement support for the family up to 13 months after the death of the loved one. So what is bereavement? Bereavement is the state or the fact of having lost someone to death. Grief, on the other hand, is the emotional reaction in response to bereavement. And it can be emotional, it can be cognitive, it can result in functional or behavioral responses as well. And it may, in fact, it often begins even before someone actually dies. There's anticipatory grief, and it can be prolonged afterwards. In fact, most people never totally stop grieving for their loved one. Even years later, widows will talk about their deceased spouse. Having been through a bereavement experience myself back in January when my mom passed away in hospice, which was a very beautiful and comfortable experience for her. But my dad still, every time I talk with him on the phone, it's been over 6 months, he always talks about her. And it's just she was part of his life for 58 years. So it's not easy, but people they just learn to incorporate kind of a new normal. But anticipatory grief, this is where people have simultaneous and overlapping grief processes. So patients are grieving the loss of their youth, the loss of opportunities, their declining health, losing function, their role as provider or as the leader is being threatened or disrupted, their identity, which is, if people are tied up in their identity of what they can do or who they are, how they can function, and that's threatened, then they have an identity crisis. They feel like, well, what worth are they? And is life worth living? They may feel, they're grieving the loss of the life that they hope they would have been able to live. Families, they have grief related to their expectations, their dashed hopes for how life was going to be. Psychosocial and spiritual and physical grief about the loss of function in those areas, and of course anticipating the loss of their family member. So it's helpful to help them foster hope in realistic ways. So setting attainable goals, asking what they're hoping for right now, given this new reality. What is it that's important to them? And the focus on being rather than doing, being the husband or the wife, the child, the caregiver, being there for them, just being present is sometimes more important than doing. And there is the Hearth Hope Index. I just mentioned that briefly, but that's one of the ways that you can assess people's sources of hope and how they're coping. There are some psychotherapeutic interventions which are useful before death. You'll probably see this on the boards, but dignity therapy. And this is really, it can either be written or recorded, through audio or even video, where people kind of reflect on their life and what things gave life meaning, how they feel they helped others or contributed to others or made a difference, what kind of legacy they're leaving. And then also meaning-centered psychotherapy, where they're focusing on the meaning of their life and how they influenced or impacted other people. So these are things that can help people kind of focus on the positive aspects even before they pass away. Now, normal grief is a process, and it's not a state. It does vary over time, and it often involves a broad spectrum of emotional, cognitive, social, and behavioral disruptions, both positive and negative emotions. Positive emotions like remembering the good times they had or how wonderful their loved one was who's passed away, but also the negative emotions, the sadness, the crying, the depressed mood, the yearning, the emptiness, the disbelief. And it can carry over into physical symptoms of grieving. So fatigue, that's huge. People just don't have any energy to do anything, and they don't feel hungry, and they don't sleep well, and they lose interest in things around them. They're just kind of focused acutely on the loss. They're kind of, life kind of comes to a standstill for them. They may be restless, they may be irritable, they may feel guilty. Oh, I should have seen this coming sooner. I should have known. And then over time, they develop what's called a more abiding or integrated grief, which is like the new normal. It's where they can go on with their life, but yet they still, in the back of their mind, they're still continuing to grieve the loss of their loved one. And grief is not only about separation from the deceased person, but also about finding new and meaningful ways of continuing the relationship with the deceased. People, they go to the graveside, they talk to their loved one, they have pictures around the house. They think about their loved one as they're doing things and wondering, well, can their loved one see them now? There's just a lot of different ways that happens. Now, where this becomes a problem is where it becomes abnormal, or what the former term was complicated grief. The newer term is pathological or prolonged grief disorder. And again, you're going to see this on the boards because they want you to know what's normal, what's abnormal, and when do you need to intervene, when do you need to treat, and how do you distinguish this from depression. So we'll touch on that briefly. So prevalence is about 10%, and some of the risk factors are a sudden traumatic loss, especially in people who are younger and unexpected. If they have poor social supports, if they have concurrent life stressors, and the more losses that they experience at the same time, the more risk of prolonged grief disorder. And then also if they have a history of mood or anxiety disorders, that just makes it more likely that they're going to experience this. Characteristics: duration is often prolonged, and it's usually more than 6 months. So if somebody is having disruption in their function and they're having a hard time just functioning after 6 months, then it's definitely what you would consider prolonged grief disorder. They have difficulty accepting death, and they fail to integrate the grief. They fail to achieve a new normal. There's intense separation and traumatic distress. And they engage in maladaptive behaviors. The intense yearning becomes the focus of their life, such that they can't really do anything else. They have a hard time with their job or their other social interactions. They become reclusive. They may feel sad, frustrated, anxious, and fear like life is over. They may become either over-involved or excessive avoidance of the memory or the mention of their loved one. Either it's, they're so focused on it that that's all they think about, or they completely try to avoid the topic. And they often become estranged from others. Diagnosis requires 6 months after death, and there is a scoring or scale that you can use. It's called the Prolonged Grief Disorder 13 or PG-13 revised. Every score has to be revised at some point. So this is now the PG-13R, and a score of greater than 25 indicates prolonged grief disorder. And basically, this score, it's rated either since the death or the result of the death, and it has a number of questions like: do you feel yourself longing or yearning for the person who died? You have trouble doing things you normally do because you're thinking so much about the person who died. And then it's scored as not at all, slightly, somewhat, or quite a bit, or overwhelmingly. And so, these questions, there's a number of questions, 13 questions that it goes through, addressing basically their emotional and their functional responses. And if you get a score, or if the person gets a score of 25 or more, then that's considered significant. And so the consequences of prolonged grief is that it tends to be chronic and unremitting if it's untreated. It causes significant distress and impairment, and negative health consequences, increased risk of cancer because of depressed immune system, increased risk of cardiac disease. I'm sure you've all heard about the broken heart syndrome. It's a real thing. Somebody has normal coronaries, but their EF is 15 to 25%, and they're in heart failure because their heart is literally broken heart. Hypertension as another possible consequence, and increased mortality, including risk of suicide. And so treatment is targeted, and actually general psychotherapy alone may be helpful, but targeted, complicated grief treatment is superior. And this involves cognitive behavioral techniques, interpersonal psychotherapy, and motivational interviewing, and helping them set personal goals, step by step, little by little, trying to move them in the right direction. And then coming to terms with loss and finding a pathway to restoration, getting them plugged in with other social supports, psychosocial and spiritual supports that can help them kind of get out of the swamp that they're in and onto more solid ground. And then antidepressant medications often are needed for at least 3 months once this is diagnosed. And one of the things, they used to say that you shouldn't use antidepressants unless they've been grieving for at least 2 months or are diagnosed with major depressive disorder. But actually what they find is that the antidepressant medications can be helpful even before somebody's been grieving 6 months. So major depressive disorder is precipitated from grief or bereavement of 11 to 42% of the time, and so it's not insignificant, and it results in low mood, sadness, loneliness, and crying. Major depression can be diagnosed along with bereavement based on the new DSM criteria. The bereavement in and of itself does not exclude MDD. The best predictor of major depressive disorder at 1 year is feeling really depressed at 1 to 2 months. And it's more pervasive. It involves more protracted and enduring low mood as opposed to ups and downs throughout the day. People have difficulty experiencing self-validating or positive feelings. They have poor work and social functioning and pathologic immune functioning. They feel guilty, worthless, helpless, suicidal. Often they feel suicidal. And another feature is that they have psychomotor retardation and or functional impairment. So this chart I thought would be helpful in exploring the differences between grief versus major depressive disorder. So emotionally, with grief, people feel empty, they feel loss. With major depressive disorder, they have depressed mood and they have anhedonia, the inability to experience pleasure. Whereas in grief, they can experience some pleasure if needed. Dysphoria with grief occurs in waves triggered by thoughts and memories of the deceased. Whereas MDD, it's unrelenting. It involves feelings of worthlessness and hopelessness. Their mood state in grief is reactive, and they can experience positive emotions too. Whereas MDD, it's pervasive and intractable low mood. Self-esteem is preserved with grief, and guilty feelings are only related to the relationship with the deceased, wishing they had done things differently or something like that. Whereas in MDD, their self-esteem is low, and guilty feelings are unrelated to the relationship with the deceased. They feel guilty about everything, not just the relationship issues. Thoughts of death. With grief, they often concern joining the deceased. Maybe it may be a passive wish that they'll just die in their sleep and go be with their loved one. Whereas MDD, thoughts of death are aimed at ending one's own life. And they're rooted in feelings of hopelessness and worthlessness. And then effect on function, grief initially reduces function, but then afterwards it's variable. Whereas MDD, it is persistently impaired function. I guarantee you will see questions like this on the board, so it's important to know. So choose your words wisely. This is another helpful slide that I thought would be useful, because in dealing with bereaved families, what do you say to them? So there are certain things that you shouldn't say. So like they're in a better place, and some of these things they don't seem terrible, and I've been guilty of saying them too. But I think that the intent is that, like, please let me know if there's anything I can do for you. I don't think that's a terrible thing to say, but I'm sure that the families probably say, well, there's nothing you can do to me but bring my loved one back. So it may not be helpful in that regard. I know how you feel. Usually families feel like, well, how can anybody know how I feel? I guess we all die eventually. That really doesn't help. Everything happens for a reason. You're strong enough to get through this. Whereas it is helpful to use empathy. This is so sad, and I'm sorry. I wish you didn't have to go through this. When you're ready, I can come over and help out. That's a little more specific than just let me know if there's anything I can do for you. Tell me more about the name of the deceased. I can't imagine how you're feeling. This is a terrible loss. I imagine it's tough for you right now. And sometimes there are just no words. Sometimes simply being present with the bereaved can be the best approach. So in summary, we've identified the physiologic and prognostic signs near end of life, identified ways to support families and address common concerns, identified and talked about treatment of symptoms at end of life with comfort care, and identifying complicated or uncomplicated versus complicated grief and major depressive disorder. I'd like to end with this quote: "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." This is from Dr. Cicely Saunders, the founder of Modern Hospice, St. Christopher's Hospice in London. What questions do you have?
Very well done, Mike. Appreciate you presenting this. Let me just put a video on here. So thanks for doing this. I just wanted to make a comment, and I think you might have touched on this, but I think it warrants just at the very beginning. You were talking about the PPS and the PPI, and the prognostic implications of the scores of those, and it's probably self-evident, but I've seen it misappropriated sometimes. That's in the course, in the context of having a terminal illness, when you get those numbers, because you can have people that are that have low PPSs, but it's not in the context of terminal illness. They have poor functioning because of their obesity, orthopedic issues, and poor mobility issues, and they're not eating much. And you'd say, oh my gosh, they've got a PPS of 40 or 30 or something of that nature. So it's always important to keep in mind that is in the context of a terminal illness.
Yeah, following the trend over time. So if they're declining month by month, right, then they could be months to a year or more. If they're declining week by week, then it could be weeks to months. If they're declining day by day, every day they're getting worse, then it's probably days to weeks. So seeing that context of where they're coming from, and then evaluating where they're at right now, and then kind of drawing a predictive line forward to estimate where they might be in the future can be helpful. And again, the caveat is that if the current trends continue, this is where we're headed. But if people stabilize and improve, well, then their prognosis is going to be longer. And at least identifying that the prognosis or that there is risk of mortality within the next whatever time period it is. So therefore, let's talk about what's important to you and how you want to live your life, and how can we help you achieve your goals for whatever time you have. So those are important tools that you can use to springboard discussions about goals of care.
Mike, Jay Beckrow here, and thank you for this excellent presentation. I was taking notes throughout, and I look forward to chatting with you about these. But some big things I wanted to kind of reiterate for our fellows that are here. Early on, I think one of the early slides, talked about the whole concept of goals of care. What my students and everyone will hear from me a lot is the concept of let's move this conversation as upstream as we possibly can, because a lot of times our fellows will be called into, say, an emergency room situation in ICU, when now we're at a critical physiologic event. And we do, by and large, live in a culture that's relatively uncomfortable talking about dying, kind of a death denying. In fact, there was an excellent presentation at HPM a few years ago. Help remind me, UA Birmingham, who was the gentleman? Think of the.
Well, Rodney Tucker was there.
Tucker, thank you.
Rodney was their program director back in the day.
And I'd like to, as you go through your year here, within that culture, how we can then leverage, your influence and agency to help people have these conversations. So a lot of what we'd like to talk about is how we move this upstream, but for the context of that critical, like in the ICU and ER, helping the families, with goals of care. I love how you talked about the language. Could you go back to that slide, one of your first ones on the prolonged or complicated grief? And I'd like to extrapolate from that the concept of a lot of times you'll be going into really highly emotionally charged circumstances, right? A situation where someone is critically ill. Everyone in the health system who's wearing a badge knows the outcome. The family has goals that are probably not relatively physiologically realistic. And what I wanted you to focus on is in the prevalence there. Look at poor social support and concurrent life stressors. I mean, who at this table or even on this call doesn't have concurrent life stressors? And what I'm trying to get our fellows to think about is when you're in those situations, right? And when everyone knows how this is going to go and quote unquote, the family's being difficult, they're being, they're wanting inappropriate treatments. And sometimes we move toward judgment. What we're going to ask is to think about what concurrent life stressors they may be bringing to that circumstance. And then even things like prior traumas, adverse childhood events and things such as that. So, Mike, I just wanted to thank you for having that in your slides, and we'll be talking a lot about that with our fellows as the year goes on. But excellent presentation, Mike.
Yeah,
thank you.
Thank you.
Thanks, Jay. Other questions for Mike? If not, we will go ahead and close out this session and pivot to our case presentation for today. Which you've got a case, right? Yeah. Okay, you guys can switch places. Yeah.